Good evening. My name is Roxanne Chabot from RBC Consultants. Thank you so much for joining us this evening to discuss on burning out acne, a fireside chat with your peers on real-world acne cases. So this evening as presenters, we have Dr. Charles Lin, who's Chief Medical Director at the Lin Institute of Dermatology and Lin Derm Research and Associate Professor at the University of Toronto, Department of Medicine. We also have Dr. Jaggi Rao, Clinical Professor, Division of Dermatology and Cutaneous Sciences at the University of Alberta, and Founder and Medical Director of Telederm Canada, as well as, of course, Dr. Rao is a board-certified dermatologist. We'd like to thank our supporter, Cipher, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you'd like to ask a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and we will be emailing you the same survey 1 to 2 days later. We'd greatly appreciate if you would fill out this survey for us and send it back. Within 1 to 2 days of the webinar, the recording of this program and a certificate of attendance will also be emailed to you. Again, if you have any questions, please submit your questions using the question chat pane on the right-hand side of your screen, and I wrote a little note there for you so you can see where you need to type it in. The opinions expressed in this presentation are that of the presenters. They do not necessarily reflect the opinions of Cipher Pharmaceutical, Inc. So without further ado, what I'm going to do is pass the floor virtually to Dr. Charles Lin.
Thank you very much, Roxanne, and thank you to all the attendees for another evening on talking about dermatology. This evening's on treating mild or moderate to severe acne, burning it out. I think.
If you click in the middle of the screen.
Yeah, I clicked it.
There we go. You're
all
off.
right. Okay, got it. Okay. Good. So tonight we're going to talk about burning out acne, and it's really going to be through real-world cases. And we've got a number of cases. I think there's 8 of them here. Some of them are regular acne, some are some mimics, and some are other off-label uses for use of isotretinoin. So I want to start by just a couple of quick things. The 5 commandments for treating acne. But really, why is it important to treat acne? Well, acne, we're going, sorry folks. The first commandment really is to treat acne early and aggressively. And I think all of you know that acne unfortunately can produce scarring, sometimes a little bit, but can produce sometimes in some people quite an amount of scarring with pitting and also with cuticle scars. And the big thing is prevent them, because our treatments for scarring are less than satisfactory. The old saying about the ounce of prevention worth the pound of cure. And this was recognized by a number of dermatologists back in an article in the year 2000. And it was the first one actually in the world that really said, you know, if you have any amount of scarring, you should be aggressively treating that patient early and aggressively so you do not get the scarring. And it was our quotation mark godfather of Canadian dermatology, Dr. Madden, that came up with this idea and came up to a Canadian consensus guidelines surrounding this. We know that acne can have significant social, psychological, and physical consequences. It certainly is associated with lower self-esteem, anxiety, depression. You get negative emotions, embarrassment, humiliation, self-consciousness. And unfortunately, it also has a social economic impact because it shows your perceptions of others. And people that have had bad acne have greater rates of unemployment than those with having normal skin. And again, acne scars lead to a damaged quality of life. Commandment number 2, take isotretinoin with a fatty meal. And you don't necessarily have to have one of these big burgers to do it. But basically, fat causes better absorption of isotretinoin. And basically, fatty things can be milk, can be yogurt, can be ice cream. Some people like that when you say. It can be a little dollop of peanut butter. It can be a Big Mac or a Whopper or whatever. And that's been the thing for isotretinoin. But we now have a newer isotretinoin over the last several years, the Purus. And you can see in the slides there, this is a great improvement over the older isotretinoin that always had to be taken with something fatty. And as you know, many of the people that are getting treated with the isotretinoin are teenagers, young adults. They often don't have a lot of fat in their diet, or they're always on the run. They want to take the pills on a fasted state. They just want to pop them down. And that's the big beauty with the Purus. Purus, if you have it in a fasted state, essentially identical to isotretinoin, the older Accutane. But if you are in a fasted state, you get 83% greater absorption, and this translates into better efficacy and quicker results with the treatment. This is because there is a special isotretinoin lipidose technology that allows the drug to be in already a lipid, gives you a better absorption and the higher efficacy that you're seeing with this drug. My commandment number 3 is remember the mimics. So all things that look like acne aren't necessarily acne. And there are a number of other things. And you can think of perioral dermatitis, rosacea, angiofibromas, flatwarts, sebaceous hyperplasia. There's a fairly long list, but some of these are the more common ones. And a number of times I've been, family doctors have asked me to see a patient, please see regarding severe acne, put them on isotretinoin, and I go, whoa, these are all flatwarts. They need to be treated differently. The next one is commandment number 4. With isotretinoin, go low, go longer. And really, there's not really a necessary hurry. I was there in the initial studies back in 1980, 81, 82, when isotretinoin was being studied. We used big doses. Oftentimes you started at 1 milligram per kilogram and you went to 2 milligrams per kilogram, and you try to get this all done in 4 months. What's the hurry? You can start lower, 0.5 milligrams per kilogram, and as your first dose and move up to 1 milligram per kilogram. But a lot of my patients, I actually stay at 0.5 milligrams per kilogram, and I just go longer. Typically, I go until I don't see any more disease, any more lesions coming out. And that may mean that I go 7, 8 months instead of only 5 or 6. I think you get less side effects and you get less people coming off the drug because of the side effects. And my commandment number 5, just be aware when you should investigate. There are danger signs. And some of these danger signs would include in a woman irregular menstrual periods, hirsutism, signs of virilism, really severe acne, a younger age, so a age that might be 11 or 12 and they're getting severe acne, or a older age. And polycystic ovarian syndrome is fairly common. And again, you should be thinking about this because in fact, you may want to be treating them endocrinologically by something like spironolactone to help them in addition to using potentially isotretinoin. So isotretinoin will often clear some of these patients, but they will often reoccur fairly quickly. So thinking about this beforehand can tell you what your best avenue of treatment might be. So now we're going to really move on to the meat of the evening about real world cases. And this, I think, is the crux of tonight. These are a number of cases that are actually real world cases that come from our practices that we'd like to make some teaching points about. You have 2 kind of key opinion leaders, people that have been treating acne for quite a number of years. In my case, it's about 40 years. Jaggy, I don't think is quite as old as I am. He looks a lot better. He does a lot more cosmetic surgery. That's why he's saying. But again, an expert from two ends of the country. I'm in Toronto, Jaggy's in Edmonton, and we have probably some similarities, but oftentimes we may, as dermatologists, treat it slightly differently. So case one, Jaggy, and by the way, Jaggy's a great friend of mine, and you know, Jaggy's an excellent dermatologist. He's a surgeon, a cosmetic surgeon also, general dermatologist, and Jaggy always has different things he likes to do. And right now, I think one of the big things you like to do now, Jaggy, is telemedicine. And a lot of this acne actually can be looked after over telemedicine. It's not necessary that you all have to see all of this in the office. So Jaggy, you got the first case.
Well, thanks very much, Chuck, and thank you for all of you for attending today. And this is going to be a little bit of a different talk than what we've done in the past, where usually we go through the pathophysiology of the condition, and we're not going to really do that. I thought we'd just go through some cases, and as Chuck had said, we have different practices and possibly even different opinions, but I think it doesn't quite matter as long as the patient gets better and as long as everybody's safe. And hopefully we'll show you today 8 cases, I think we have. They all come from real world scenarios, most of them from teledermatology. So I agree with Chuck's point that all of this has been handled remotely and people have gotten a lot better, if not completely clear. We're going to share with you some of our insights beginning with case number 1. If you do have any questions, as Roxanne said, please don't hesitate to use the chat menu. We're going to mute everybody, but we'll definitely read your cases and your questions. And by all means, ask anything that you want. Here's your chance. So with that, let's take a look at case number 1. Here we have a gentleman who is, I believe he's a 23-year-old gentleman, and you can see he's got multiple inflammatory papules on his back, and you can see that it's quite widespread on the back as well. If you zoom in, it might be difficult for you, but if you try to zoom in, you'll see that there's different types of lesion in the same presentation. So not only do you have inflammatory papules, there's also some comedones, so you can see blackheads and whiteheads, and there might even be some pustules there. I don't know if you can see my arrow, but here there's a pustule. And if you feel the skin, here's another pustule. If you feel the skin, you might even feel some cysts. So when we talk about the different lesions of acne, the morphology is all presented in one back here. And we've prepared a few questions for you. You can see if this, so this is the same patient. And you can see it's not only on the back, but it seems to be on other areas of the body as well. So you notice the cheeks, not just the hair-bearing area, but also the central part of the cheek that doesn't have a lot of hair, even encroaches down into the submental region and the neck, which isn't uncommon for this presentation. And I should mention this patient is a Caucasian male. It's pretty obvious, but sometimes it's good to know that because as you'll see with later cases, sometimes it'll be different in terms of our approach and our considerations. So one of the questions, the first question we ask is, what is your preferred diagnosis? And Chuck, do you want to go back and forth with this, or how do you prefer we handle it?
No, sure. No, I'll talk. So, yeah, you know, Jaggy, this is in my mind not a mimic. And one of the things that you know about acne, a lot of people don't show you this. You know, this person may come into your office and they will say, you know, I've got some acne, and you look at their face and you know, oh, this is kind of grade 1 acne only. I can probably treat it with a topical. But, you know, I think it behoves us as physicians that are interested in the skin to certainly look at the chest and back. And you could have minimal acne on the front and fair amount. In general, you would have all of this going on in the chest and back at the same time. And always. So as I mentioned, not a mimic. I mean, you can just kind of look at this in 3 seconds and you go, oh, this guy's got cystic lesions. He's got scars going on there. He's got an extensive amount. This guy needs help. And often the history is he's been ashamed of not telling anybody about this. He often won't tell his mother, father. When he plays hockey, he dresses in at home or whatever else, and so all his friends don't see it. So he needs help. He's got cystic acne. We've got to find a solution to improve this guy's quality of life and stop that scarring.
The other point I'd make is that you can even tell just by this picture that it's been going on for some time. It's not just something that happened a week or maybe even 2 weeks ago. It looks like it's probably been going on for weeks, if not months. note the post-inflammatory hyperpigmentation that's there. And there's also another form of post-inflammatory change, which is called post-inflammatory erythema. We might see that on the face where you just have these flat red spots, but probably has been going on for months, would you say, Chuck?
Yeah, I would agree. We have a new retinoid that is a topical, a cleaf that is specifically for back acne. It's been studied in it, but this is too extensive for just a topical. You need a systemic here. So if you have some acne on the back, some acne on the face, it's more grade 1, 2. Yeah, you could be using a topical, but this guy obviously needs something systemic. I mean, in the old days when I was practicing, 20, 30 years ago, we didn't use a lot of Accutane as much as, or isotretinoin as we do now, and we'd probably try using some doxycycline, minocycline, but we've got better treatments now, as I just mentioned in my first opening.
Yeah, I would agree with that. One of the second question that always comes to mind, should we perform any type of diagnostic workup? So I just finished quizzing our final year residents who just finished writing their final oral exam. And we asked, what kind of diagnostic workup would you do? I'll share with you what I shared with them is that when you think about workup, there's really 4 things that you should consider. One of them is physical examination. So do we need to do any more physical exam? Second is laboratory tests. So we're talking mostly serum, so blood. 3 is radiology. Should we do any radiology? And 4 is pathology, and possibly a 5th, which is microbiology. So what do you think about that? I'll let you think about that and ask Dr. Lind. Is there any workup you think would be necessary clinically for this patient?
Well, as dermatology, you want to do a full skin examination. This can be associated with like hidradenitis. It can be associated with folliculitis decalvans in the scalp. So you'd be looking at those areas, but those take you 3 seconds to kind of look at the rest of the skin. I would bet that mainly you would have what's on the back, the chest, and the face. Yeah, if the guy had been on kind of a year's worth of antibiotics, maybe you want to do a culture to make sure he's not got gram-negative folliculitis. I kind of doubt that's happening here. X-ray, maybe, because very severe acne, conglobadic acne, can be associated sometimes with X-ray changes, but and generally I don't do that. I think it's really, this is a physical looking at it and jumping and doing some treatment.
Yeah, I would agree with you. And, if we just saw the face picture, you might not think it's that severe, but then, I'm sure you see this even in your practice. Sometimes it looks clear on the face or relatively clear, and then you look at their back or their chest and like, wow, this is pretty intense. Not only do you have deeper cysts and nodules, but also it's very widespread. So I do agree. I think this patient deserves to have a little bit more aggressive therapy. So here, maybe I'll ask the question and kind of answer it. What are the principles of management? There's a few things I would think of. Now, this does go back to the pathophysiology, but we didn't really show it. But remember, there are 4 pathophysiological factors that are causative factors, if you will, that are contributing to acne. One of them is oil production. Most cases, patients who have acne like this usually have an elevated oil production. So that's number 1. 2 is there's often clogging of the pores. So there's hyperkeratinization. So that's translated by pore clogging, and we talk about macrocomedones, whiteheads and blackheads. The third is going to be bacterial overload. So usually there's increased bacteria accompanying that increased oil levels. And then finally 4, there's inflammation. So I think if you can reduce all 4 of those elements, this patient should technically clear.
And guess what? Isotretinoin attacks all those areas.
It does. So with that, what would be your first line therapy, Chuck?
Yeah, I think you're reading me. This is an isotretinoin candidate, unless there's some contraindication that you haven't told me, because I think this fellow needs a aggressive therapy and needs it now.
Yeah, I would agree. So I totally agree that isotretinoin is probably the first line therapy. You could attempt maybe antibiotics, and we talked about topical retinoids such as triferritine, which is a cleaf. But in our experience, we can tell you it's probably best just to jump to isotretinoin.
But one of the things, Shaggy, I see some, and I'm sure in your practice you see some of these. You see this, and you as an experienced dermatologist and myself as an experienced dermatologist, that's the treatment. And you got a parent sitting in the room. And oh, I don't want my son to go on this, or my daughter, I've heard all these different things. I don't want them to go on it. And you go, but ma'am, this is the best thing. I make a kind of a pact with them. I say, all right, fine. I respect your wishes. It's your kid. And we'll give them 3 months worth of intense antibiotics, doxycycline, minocycline, whatever, the best topical you can throw at it and everything else. And you're going to come back in 3 or 4 months, and we're going to see if it's made any benefit. And it probably will have made a benefit, but I would bet that for the most part, most of the people, the kids are not happy. The patient is not happy enough with that. And they go, that other drug that you sent me home with the pamphlet on, I'm ready for it. I can't stand this. You told me that we've got to get this under control, and I want to get started on getting rid of the scarring.
Yeah, that's right. I used to do that too, but now I just tell them, you know what, we could do that, but I guarantee you're probably going to regret it because you're not going to see too much change based on my experience. Also, you're losing time. You're losing valuable time socially. We didn't even talk about how socially debilitating this could be, but also look at the scarring. He already has scars. Let's stop that scarring process. I tell people, most people who go on to isotretinoin, not only do they love it, the results of it, but they also say if it's done appropriately, I wish I did it earlier.
Yep.
So I agree with that. So which isotretinoin would you recommend?
Well, again, in my first bit there, oftentimes these people, it's better to have one that I think works quite a bit better. And I think that's because it seems to, in my hands, seem to have less side effects. So Epura seems to have less side effects than the older isotretinoin. And it also, because of being able to be on a fed state or a non-fed state, gives better absorption. I think it works more efficiently.
Yeah, I agree with that. I haven't seen quite the side effect profile that you see with Accutane or even Claris for that matter, the generic version of Accutane. I would go Epuris right away. What dosing would you start at, Chuck?
I usually about 0.5 milligrams per kilogram. So a typical patient I would give them 40 milligrams. And that's the other thing. I'm an older dermatologist, and I keep it simple, stupid, the KISS idea, because you can, do out your math and everything else, and then they're taking 50 milligrams. Basically, this drug works so well. You just go, if you start with 40 milligrams and you move up to 60 or something, you just go a little bit longer until you achieve your effect that you want. And so people are often seeing, they're taking 310s and 220s and all these other things. I just try to keep it simple for my patients.
Yeah, me too. And in fact, you'll find in my practice, I did an audit of my isotretinoin practice, and I found that about 90% of what I prescribe will be 40 milligrams a day. And typically it's about 2 to 4 months, sometimes 6 months, but I've never had to go more than that.
Good.
So let's see, we'll talk a bit more about that as we go by, but we do have a polling question for everyone. That's okay. So you'll get the poll up in a second. The question is, what is your first line prescription therapy? We probably should have talked about it afterwards, and don't let us bias you, or maybe we can reword it and say, what was your first line prescription therapy before hearing about us discuss the case?
Roxanne, we're waiting for the polling question.
Yep, it's coming up.
There you go. So yeah, we may have biased you a little bit. Oral isotretinoin seems to be definitely the highest one. And then some people said topical retinoids and oral antibiotics. You certainly wouldn't be wrong, but if you wanted to go fast and you want it to be predictable, I would say I would agree with the first one, oral isotretinoin. Chuck?
Yeah, I agree.
So I think I just have one more follow-up question, then we'll go quickly to the next case. Yes, alternative prescription therapy. So some of them were written there. We talked about combination therapy, so topical retinoid plus oral antibiotic. And that's pretty good. You'll be able to cover off at least 3 out of those 4 pathophysiologic factors. But one thing that they don't talk about is the speed, the rapidity of doing that. I don't think you can hold a feather to isotretinoin.
Yeah, again, as I mentioned earlier, I've been using quite a bit of a cleave for milder acne. I find it very useful. It's good retinoid. It's very well tolerated there. Sometimes it can be a little drier on the face, and you have to have regimens that may include a moisturizer. Oftentimes we need a moisturizer for retinoids. What is if the patient is planning pregnancy? Well, he's a male. I don't think he's going to get pregnant. Again, it's not a problem if his spouse or girlfriend is intending to get pregnant. There's not enough transfer of the isotretinoin to worry about it.
Yeah.
Okay, we'll go on here, Jackie. So case number 2 is, I think, mine, Jackie.
Yeah.
Yeah. Okay. So this one is a patient that has it on the face. He's about 16 years old, Hispanic, so non-Caucasian, if you would. If you look at that face, you can see the nodules, the cysts, and you can see a lot of scars. This guy needs help right now. Okay. And that guy, poor fellow's quality of life, even wearing a mask right now, you can see large areas that he'd be quite ashamed with. His quality of life is quite bad. He doesn't have any really lesions elsewhere. And this one came up fairly quickly. So this fellow, he said he had mild acne, he was using mild retinoid or benzoyl peroxide, tried that, and then a bunch of over-the-counter measures, and then whoops, sort of like within a week, he goes, it just exploded, Dr. Lind, and I got all these lesions there. So again, any diagnostic workup here, Jackie?
No, I just do a complete exam, see if it's on his back, try to determine how much scarring is there. Sometimes he might even have sinus or fistula formation. You wonder if he has something else also going on, maybe testosterone, or perhaps even there might be some steroid usage, anabolic steroids. Sometimes we see that for young men. But I think the big point in this one is the fact that he has ethnic skin. Even if he wasn't this severe, I'd probably treat him as being severe because of the tendency of ethnic skin to scar.
Yeah, not only the kind of real physical scars, but also the pigmentary scars that are going to occur.
Yeah.
And principle and management, I guess, pretty much the same as we went through Jaggy before. We've got to improve this guy's quality of life, and we've got to do it now. There's no fooling around with this one. Jaggy, you potentially going to put this guy on a little bit of prednisone before you start?
That's a good question. So yeah, that's a really good point. I mean, there's a lot of inflammation here to the point that he's almost got acne conglobata. Conglobate lesions are the ones that are very cystic and nodular and scarring. And it looks like he may have that indeed. So a good anti-inflammatory, like a bit of prednisone, maybe even 20 or 30 milligrams a day for 5 to 10 days, wouldn't be uncommon for a good dermatologist to do that.
Yeah, because what a little history I gave you there about it coming up explosively. This would be the type of one, if you just started him on isotretinoin by itself, you're likely to get a fair amount of further flare. This guy is already dealing with quite a bit. You get a flare that might be not only bad looking, but also leading to more scars, but also painful. And again, my principle before, go low, go slow, and get it, because if you put this guy on 80 milligrams of isotretinoin, you're going to really get a very explosive thing. So a little bit of prednisone on board. I would start him maybe at 20 milligrams of isotretinoin first, and you can always move it up. You can get this better.
So just a quick aside, Chuck. I've seen several people been put onto high doses of Accutane in the past, and it's caused such an increase in inflammation that we even had to hospitalize a couple people because there's so much inflammation in their skin that the white blood cell count is low in their serum. So you definitely don't want to do that. I agree with the go slow process and maybe add a bit of prednisone.
Okay, so you've decided. I think we've already talked about this. Go slow with the Puris. We now have another polling question. So you made the decision. Can you put up the polling question? Yeah. You made the decision that you're going to use isotretinoin in this particular case, and particularly Puris. as the isotretinoin that you want to use. You've discussed with him, you discussed with all the side effects and everything else. Now it comes down to what are you going to order to fulfill the requirements that he should have. And here's your different things, CBC and differential, ALT, lipid profile, urine pregnancy test if he was female. This guy's a male, but if the case was a female, or all of the above. Can you vote now? Okay, I guess some people voted and some people didn't. Okay, so just basically, Jackie, what do you think about this? Obviously, you get the urine pregnancy test. I do a beta.
Yeah, I do both. I think you should follow this because this does correlate with the Canadian guidelines, and the Canadian guidelines are up to date and they're correct. So at least you can fall back and say, hey, I use these guidelines. So they're recommending baseline and at least for the first month to do the serum test, but for the pregnancy test, they're recommending it in females for all months, once a month until you're finished with the isotretinoin.
Yeah, I've just found that doing a beta HCG is so much more reliable. That's the one thing as a dermatologist that I don't want to get sued over is a unwanted pregnancy. And you know, the monograph says 2 forms, right? 2 good forms, so you can have a birth control pill and foam and condoms. You can have an IUD, foam and condoms type of thing. And you have to kind of put the fear of God in people. And I kind of joke about it. I say, you know, listen, if you get pregnant while you're on this, Dr. Lynn's going to come after you and probably kill you. But I know your parents are too. So if you're going to die 3 times. And they kind of laugh and things. But I really put the fear of God or whatever you want to call it into them that they must not get pregnant while they're on this.
I'll share with you a little funny phraseology. So when I was studying dermatology, people used to say, you cannot get pregnant on this, you cannot get pregnant. And then some people took that to mean, well, it means it's a birth control pill. I cannot get pregnant. So we change it to, you must not get pregnant.
Yeah, must not. Very good. That's so true. Jackie, alternative treatments to this? You know,
yeah, I don't think so. You know, I think the question is just going to be, do you get prednisone with the Epuris or not? And I'd put them on 40 milligrams a day for 4 months minimally. Follow up with them before that, perhaps, and just make sure that the blood work's okay.
Yeah. Okay. And okay. Again, I think we've answered that. We've got this stylized. We've answered it fairly well, I think, with the first case. All right. Case number 3. This one's yours, Jackie.
Yeah. So case number 3 illustrates something a little bit different. In this case, we're taking a look at the lower back of this patient. You're starting to see some inflammatory papules. Doesn't look too bad. And you wonder, geez, does this patient even have acne? And I'm wondering if there's any other areas of involvement. So let's take a look. In fact, there is. So not only on the lower back, you're starting to see on the shoulders, the posterior shoulders, as well as on the forehead. We didn't want to show you their face just to protect their identity, but there's more than one site of involvement, and I would be comfortable in calling this acne. You also see there's comedones there, there's a few inflammatory papules, and it doesn't necessarily have to be cystic to consider this to be severe.
Yeah, so yeah, I agree with you. You know, this is, I think, basically because of its extent, you need something systemic, right? You could potentially use a topical retinoid, benzoyl peroxide. If the person was saying, I just care about my face, I don't really need to treat my back and my chest, but I think most people want all gone. And I think that's the kind of the main principle here. They want to, they come to you. Remember, they had to go to their family doctor and get referred in some way, whether that's by telemedicine or whatever, and they're coming to you. They obviously are bothered by it, and they wanted it treated.
The other thing is we also have the luxury of knowing what's going to happen if you let this be. So on the forehead, you can see it is already starting to indently scar. But if you look at the posterior shoulders, this is a horrible area for hypertrophic scarring. So there's a good chance that some of these are already hypertrophic scars, not just inflammatory papules. And you want to prevent that from happening, because once they do happen, they're pretty challenging to treat.
Yeah, I agree.
Okay, so first line therapy.
Yeah, so this one, I would still vote for an isotretinoin and get it treated in that way. But this one I would be a little bit softer if say no, I don't want to jump into that. I could give them a course of oral antibiotics and a topical. Again, I think you would get improvement, but like you say, you're already starting to get some scarring over the shoulders and that. And I point that out to them. People often, we as physicians kind of seen it, been there, done it. But patients really don't understand that some of those aren't just ones that you can squeeze and they go away. These are keloids, these are hypertrophic scars, and they're going to stay. So understanding that the wasting time means you're going to get more of those over time. They want to get it treated.
Yeah, so we already talked about how to initiate Epuris. What I would do is even consider 30 milligrams a day. You don't necessarily have to go full force 40 or more. Remember, it comes in 10s, 20s, 30s, and 40s. So usually I do 40, but in this case, I might even do 30. If you do 30, there's a substantial difference with respect to sun sensitivity, and also it doesn't dry them out as much. I mean, they'll still need a hydration protocol. We're going to talk about that specifically in one of the cases, but you'll see that it'll be a lot more tolerable. The other thing is I do recommend going a little bit longer with respect to your prescription. So I would clear and then maybe a little bit more than that, because if you stop it as soon as they're clear, a chance of it coming back is pretty high.
Yeah, and I agree with you. I think also having maintenance therapy with the retinoid. After I get people clear with isotretinoin, some dermatologists go, "Oh, you've graduated. You've graduated kind of from acne school. You don't need anything more. You're perfect." I must admit, I use maintenance therapy. I have them use a retinoid. Sometimes that's every second night. Sometimes it's every night to try to prevent the further acne. And then also, I think it models the scarring that's occurred. So some of the smaller ones will get better with the retinoids. And there's a number of retinoids you can use. Retin-A, you can use Steva, you can use Acleaf, you can use Tac2 Fort. All of those are different retinoids, or even Tazorac, that you might consider using.
The other thing I'll share with you is, like, we always talk about isotretinoin being monotherapy, but it isn't. I mean, we've always done the studies monotherapeutically, but you don't have to do that in the real world. So if you're using a lower dose of isotretinoin just to maintain that safety margin, why not use a topical retinoid as well? So remember, it's an oral retinoid, but using a topical retinoid, as long as they can tolerate it and you're using the hydration protocols, then you could use it. And then once you stop the oral retinoid, you can continue, as Chuck said, with the topical, and often they'll clear and stay clear. Okay, let's go on. What if this patient is planning pregnancy? So this is a female patient. What do you think, Chuck?
If they're planning pregnancy, I would delay their treatment, obviously, with the isotretinoin and say, listen, get pregnant, get that over with, finish your breastfeeding, and then come back and we'll move on from that point.
Yeah, there's
so
two
then
issues. I mean,
you would have to temporize and give them something topically.
Yeah, there's two issues. There's the medical legal issue, but then there's also the practical issue. And the fact is, if you using isotretinoin in any aspect of the pregnancy, any part of the pregnancy or history of the pregnancy, there's a good chance of teratogenicity, whether it be first, second, or third trimester. So you definitely don't want to be in that. How about after, Chuck? How long would they avoid pregnancy after isotretinoin?
Yeah, okay. In reality, one cycle is supposed to be enough for the isotretinoin to be out of your body. It goes out quickly. I must admit, I'm an older guy, a little bit more conservative, and I tell people, listen, pregnancy and having a baby is extremely important. We know that 2 to 3% of all pregnancies end up having some little abnormality. You don't want to be tarred with that because you too quickly got pregnant after the isotretinoin. I usually tell them, again, 4 to 6 months, and it's more sort of saving my butt, and then I can sleep at night. But if the person happened to get pregnant in the second month after being on isotretinoin, I would not abort the patient. You know, I would tell them, and this is where you would involve your gynecologist and everything else. But that would be a case that it would be extremely unlikely that so would not abort it. But certainly abortion, if it occurred during the actual term of the when you had them on isotretinoin.
A difficult situation. You definitely don't want to be put into that situation if you can avoid it, for sure. One of my colleagues called me and said, you know, this patient is definitely not sexually active. You don't have to worry. We don't have to do pregnancy screening. And then I interviewed them and I said, is that true? She says, no, yeah, it's true. I'm not sexually active. I just lie there. And I said, okay, well, it depends on how you phrase the question. So that's
right.
not a good question to ask.
Okay, number 4 here. I think
so this is interesting. This one is more of an acne mimicker. So this is multiple papules. They look a little bit umbilicated and they're not very inflammatory. They're a little bit yellowish pink, and we can see them on the forehead. I think we actually have a white. Let's look at it. Let's zoom out a little bit and see. Oh, there we go. So this one doesn't look like your traditional acne. In fact, people might even say it's molluscum contagiosum. I've had some people in the past even think they're basal cell carcinomas, but in fact, they're not, none of the above. They are sebaceous gland hyperplasias. So they're little oil glands that have become big oil glands. Usually they're invisible, but now they're not. So how do you manage these, Chuck?
Yeah, so, you know, I first of all explaining to the person they don't have acne and treating them with kind of retinoids and Tactu Fort and the Cleef, etc. It's not going to be the treatment of choice. These, again, it's a mimic of acne, but it actually gets better with isotretinoin. So again, even low dose isotretinoin can help a little bit. I usually use low dose isotretinoin, give them 4 to 6 months of that. And then afterwards, if there's lesions still need to be treated, then I will use either light cautery or potentially a laser beam to hopefully improve it.
Yeah, I do the same, except that I go a little bit stronger with my dose. So I'll go similar to the acne dosing of Epuris. I'll go about 30 or 40 milligrams a day, but I find you don't have to go for very long. So even 4 to 6 weeks will be enough to shrink them to the point they're either invisible or very small. And then, as Chuck said, I usually use some kind of cautery or even laser ablation to get rid of the rest. So this is an off-label usage for Epuris.
Yeah.
And then let's go, any adjuvant there? Well, we talked about lasers and cautery. Back to you, Chuck.
Okay. So this is a person who, over the cheeks, you can see a fair amount of erythema extending onto the nose. You can appreciate some thickening of the skin in that area. And you can see some erythematous papules. You don't see any comedones here. And so this lady comes in and says, I don't kind of like looking at this. And she says also, when I drink red wine, my face flushes. You know, I have spicy foods, my face flushes. So Jaggy, diagnosis?
I think this patient has inflammatory rosacea. You can see that there's a little bit of early rhinophyma. She has inflammatory papules on the medial cheeks. You can see a little bit on the nose, perhaps even on the chin and maybe on the forehead. There's no real comedones, as you mentioned, and it looks like there's even dilated blood vessels and some flushing.
Yeah, so again, this one here. So first line prescription, what would you do here, Jaggy?
Well, there's a lot of things you can do. I mean, you want to definitely reduce the inflammation, and then you want to reduce the size of the blood vessels as your typical working plan. So to reduce the inflammation quickly, you could consider antibiotics orally, or believe it or not, you could even consider Epuris or isotretinoin. It actually works quite well. You don't necessarily have to go the duration that you would with acne. Even a few weeks of Epuris could bring down the inflammation pretty rapidly.
Yeah, I must admit, I probably go with a oral antibiotic unless there is some contraindication. You know, people are allergic sometimes to tetracyclines, and they get rashes or have other contraindications to it. And I think for the most part, rosacea responds pretty quickly to an oral antibiotic. you might want to use some kind of topical, whether it's something like Metrogel, Noritate, or even Rosavir to help with that. And I think this one, I think you're probably going to look at using some laser device down the road to help with the cosmetic appearance. But
Yeah,
sometimes,
I was just saying, there's no doubt that if you use laser, once the lesions are flat, you might be able to prevent the inflammation from coming back again.
and then again, you're going to have to tell this patient it's a long-term thing. We're not curing it. I do paint out the use of isotretinoin in many of my acne patients. It's the closest thing we have to a cure, because most people, one course is what you need. I have some people that have to have 5 or 6 courses, but for the most part, most people do well with one course. Again, purist as being a possibility would be kind of second or third line for me. The thing, how would you maintain this clear skin? I think we really talked about, again, maintenance with a metronidazole therapy. So we're moving on into case
Dr.
6.
Lynn and Dr. Rao, we've got 10 minutes left. So should we pass to questions?
Yep. Okay. We're gonna do this one. Did you want to do the questions and?
Yes, absolutely. So we have several questions. The first is, how long after treatment with isotretinoin would pregnancy be safe?
Well, I think we sort of answer that, and it's individual for the physician. In reality, scientifically, one cycle, and you can, after that cycle, you can get pregnant because it's going to. I think most of us feel comfortable allowing a little bit more leeway, and I think Jaggy says 2 months. I say 4 to 6. Yep. So, and you could hear that, we're 2 seasoned dermatologists treating the same diseases, same patients here, and we have a little different viewpoint on how we treat patients. I think the end thing is we all get there, don't we, Jaggy? One way or another.
Exactly. You know what? The great thing about these drugs, they make you look like a hero if used appropriately, and they make the patient much better, which is what we want.
Another question for case number 4, why don't we use topical retinoid if it is only the forehead?
Yeah, if it was isolated the forehead, by all means, you could use just a topical. It makes perfect sense. You don't have to expose the entire body to a retinoid. But unfortunately, that wasn't the case. This patient had pretty widespread acne. I think it was also on the back. And topical retinoids, other than what we've seen with a cleaf, just have a difficulty penetrating. So I think if you want to, the way I put it, if you use topical retinoids, it might work, but the oral retinoids will work. Right? Just a question of dosing and duration, safety.
If the patient continues to get sebaceous hyperplasia, are you going to give a repeat dose?
Yeah, I do. You sometimes, again, this is a sebaceous hyperplasia. It's sort of a thing that they have that tendency towards producing it, and you can make it better, get it settled down. I tell people, will they see me again regarding this? Absolutely. I said, you'll be back to have another date with me, and we'll have to do this again.
I think it's largely true, but if they go ahead and you bring it down to close, maybe a 0 or 1 level, then you might be able to maintain it like that just with topical retinoids.
Is there a maximum milligram per kilogram total dose per course of isotretinoin?
Theoretically, yes, they say 120 to 160 milligrams per kilogram per patient per course. But you know what? If you do what Chuck and I said, if you're keeping it at 40 milligrams for 4 to 6 months max, I don't think you'll reach that in most people.
Yeah. So interesting, Jaggy. Well, that's one of the advantages when you're older and you still hopefully got your mind. I was there basically when isotretinoin started and everything else. The boys basically took that 120 milligrams per kilogram pretty much out of the hat. They picked a thing, and you do it a certain dose, and you did 6 months. Then most people they understood the bell curve and everything else. Most people are going to fit in that, and that's where they came up with that. But in fact, there's been several articles now that's kind of gone by the board. You basically treat until you are happy that it's gone. So you can't treat just for a month and it's all gone. You have to treat beyond that. get more isotretinoin into them. So typically this is for most people sort of 4 to 6 months, but it may be. I've had a patient I saw probably a few minutes before coming on to this talk. I've had him on for a year, and every time it's a bit. Anybody had braces out there? When you go back to you have your braces, and the guy says, "Oh, you're coming back in 3 months, and we're going to take the braces off." And you come back in 3 months, and he says, "No, you have to have a little bit more. There's a few teeth that aren't quite straight," and they kept going on like this. And so the same with the isotretinoin. I tell people, I think the next time you come back, you're probably going to be able to go off of this. But if you're still having any activity, we're going until we're quite happy that it's burnt out. That's the kind of the title of the talk tonight. Burn it out, burn that acne out.
Yeah, and we want to burn it out as quickly as possible, I would say, but not too quick, because it does tend to come back. So I think the 4 to 6 months is good. The quicker you burn it out, then you can go towards scarring and try to get rid of that as well.
Is alcohol avoidance necessary?
Want to take that one, Jagger?
Yeah, I guess it's a bit gray. I wouldn't say it's absolutely contraindicated, because of course it depends on the dose that people are taking. But then if you advocate it and you say it's okay to do it, then people will of course drink in excess. So I say moderation for sure. I don't. If I say no, absolutely not, they're probably going to do it anyway. So I do tell them that if you did take it at the same time, chances are you might be sick with it, because it is competing for your liver metabolism. So one way around that is to take the Epurus in the morning, and most people will drink alcohol in the evening. There are exceptions, of course, but I try to space it out. And I tell them try to keep the dosing of the Epurus pretty low.
Yeah, the other thing I tell people, I'm permissive. I allow them to have some alcohol because, again, I'm like you, Jaggy. If you tell them no, they're going to do it anyway. What I'm very insistent upon is that they don't have a whole weekend of partying and then go get their bloods taken on Monday morning, because they're going to have an increased liver function test. And I'm not going to know, I'll be stuck with knowing, oh, maybe this is related to the isotretinoin. And for the most part, we don't have a lot of liver enzyme abnormalities, but I wouldn't know. And so I say, you can't do that. You're going to have a weekend, a wild weekend, and drink to a little bit to excess, then let's do your blood test Wednesday or Thursday. Allow some of that to get out of your liver.
Yeah, and if you can understand where they're coming from, I mean, acne is a condition of young people, generally speaking, and if you understand that they might want to party a particular weekend, graduation, that type of thing, I tell them, okay, just stop it maybe a few days before and resume it after. I also say that incidentally for people who are going off on trips. So nobody's doing that right now, but when the pandemic clears, people will be going off to Mexico and Hawaii. So I say stop it a few days before you go and resume it after you come back to avoid sun sensitivity.
Yeah, all good points.
We have some more questions, but I know, Dr. Rao, you wanted to mention about the guide.
Right. So we've been working with a number of different brand name good moisturizers and cleansers, and specifically we've created a hydration protocol for you. This is an isotretinoin hydration protocol that we use for consult teledermatology, but it's yours to keep, and feel free to change the logo on the top left there to your own logo. And I like to think it's really good, actually. So I give this to every patient in clinic and also by telehealth who I'm putting on any form of isotretinoin, Accutane, Claris, or Epurus. And it's really, really good, and it's not biased. It has been done with cooperation with the companies. And if you click on the specific moisturizer, it'll actually take you to the website of that particular product and give you more information.
Thank you. Now, does Accutane and Epurus have the same safety profile?
Yeah, I think the Epurus seems to, it's obviously teratogenic, like Accutane and Claris is. But I think the overall amount of cheilitis, everybody gets cheilitis, but I think the extent and the severity of the cheilitis is less. The overall dryness that they seem to get with the Epurus seems to be less. So I'm happy. I basically think that it's a better molecule, particularly in terms of its formulation and being able to eat it on fasting or non-fasting. And I think overall it's high efficacy, and probably a little bit safer in terms of all these side effects that people complain about.
I completely agree.
When is it safe to have surgical procedures?
Maybe I'll
Jackie,
take that.
you're the cosmetic guy.
So it depends on what you're doing. I mean, if you're talking about skin surgery, most skin surgery can be done actually with ePuris if it's below 40 milligrams or below. If you're talking about resurfacing the skin, so taking off the epidermis, I would definitely wait about 2 to 4 weeks minimally before you perform that, because it does affect the oil production, which is required for healing. So that's for sure for skin. Now for joints and for other surgeries, you probably want to wait about a month or 2 months, not because it affects the immune system, it doesn't, but because of the oil productions that are involved and necessary for healing.
So Dr. Prushanowski mentioned that he doesn't believe ePuris has the peanut allergy issue that is present with Accutane.
Yeah, I haven't seen that. That's probably true.
Yeah, I agree with Dr. Piersnowski. Dr. Piersnowski and I, we trained many years ago, and Tad's always right.
Thank you, Dr. Prushanowski. What percent of your patients on ePuris can also tolerate topical retinoids? That's Dr. Sejic.
It depends on the dose. Most of the time I don't, but there are some stubborn lesions, lesions that are still pustulating despite the fact that you're going on 30, 40 milligrams of ePuris. And I don't like to go higher. I find the 40 milligrams a cutoff. If you start to go higher than that, you're starting to get systemic effects that are unwanted and undesirable. So then you might want to consider utilizing topical retinoids as well, just on the areas you need.
Yeah, for the most part, again, I tell people, this is a 5 or 6 month course. Just wait it out. You're going to get there. Yeah, the light is at the end of the tunnel. And I say that's one of the things. This is a drug that you can use by itself. You don't have to be putting topicals on when you're using this. And just wait it out. And at the end of the story, after 5 or 6 months, all the lesions are basically gone, except for the scars, obviously.
One last question. Can you combine isotretinoin with anything or any other treatment, basically?
Yeah, you absolutely can. So ePuris, I often will do light therapy, not ultraviolet light, but blue light therapy. Even photodynamic therapy has been very useful to rapidly bring down some of the cystic lesions as well as the inflammatory lesions. We talked about using topical therapies as well. Laser therapy, as long as it's non-ablative, might actually reduce the erythema faster. So if you're using a vascular laser, pulse dye laser, Nd:YAG laser, KTP laser, you can safely do it with isotretinoin. Laser hair removal, I would not, because of the fact that it uses a lot of heat and the hair follicles could be involved, and there is higher incidence of scarring if you do laser hair removal with isotretinoin.
Well, that concludes our webinar this evening. We really would like to thank again Cypher for making this educational event possible. And we also want to thank our excellent presenters, so knowledgeable, full of advice and a wealth of knowledge this evening, Dr. Charles Lin and Dr. Jackie Rao. Thank you so much for joining us. Happy to see so many familiar names with us again this evening, and hope to see you again soon live. Good night.
All right, bye-bye.
Stay safe.
Bye-bye.